Thanks to all of you for joining us for today's webinar. This is a very important offering because we're going to focus in on some practical and policy considerations in trying to overcome barriers to reducing diabetes disparities. And we're going to learn from local leaders who have been in the fray working day to day to try and overcome this terrible problem of disparities in diabetes. As Director of the National Program Office for the Alliance, I'm pleased to be able to share with you this work. I know everyone on the line is very interested in how to close the wide and growing gap in diabetes outcomes between primarily low-income and minority populations and the rest of Americans. Before we get started, I wanted to offer my thanks to the Merck Company Foundation. Their continuing support of the Alliance is extremely important, and they are also sponsoring today's webinar. The Foundation's support makes important discussions like this possible. Since 2009, the Alliance has been working to improve healthcare delivery in those populations most at risk for diabetes. And in the U.S., those are African Americans, Latino, Hispanic, and Native American adults. The Alliance's aim is to help decrease the disparities in diabetes through enhancing the quality of care, particularly related to prevention and management services. The Alliance supports 5 community-based programs across the U.S. in Chicago, Dallas, Memphis, Camden, and Wind River. And in these areas, local leaders are implementing comprehensive, evidence-based diabetes programs. And the programs have many things in common, although they are in unique areas and taking unique approaches. But the major aim is to generate improvements in the patient, provider, and health system levels in a comprehensive way and emphasizing patient-centered care. In March of this year, the Alliance held a summit in Washington, D.C., attended by leaders of national organizations. And at that summit, there was a discussion of needed policy to reduce disparities in diabetes. The summit's policy considerations evolved as a result of in-depth discussions and interviews with the Alliance community program leaders, guidance from a very distinguished steering committee and other experts working in the field, as well as examination of research findings. The Alliance's policy considerations advance the idea that we need to realign financial incentives for 3 key groups: patients, providers, and of course health systems. A summary of the summit discussion and a summary of these specific policy considerations will soon be on the Alliance website, and I do hope you'll take time to look over this summary. I think you'll find it informative. The Alliance is also hosting a series of webinars to further explore the policy considerations for reducing disparities. Today's discussion is the first in this series and is focusing on the experience of Alliance program leaders. You're going to hear about the importance of access to comprehensive community health data, to establishing effective community relationships, and integrating community health workers into clinical systems. We're very delighted that Dr. Jeff Levy is moderating today's discussion. He has long-time experience and deep expertise in a range of health policy issues. Jeff is Executive Director of the Trust for America's Health. He's going to introduce the panelists and kick off the discussion. Also participating are 3 of our Alliance site leaders, and they're going to tell you about their firsthand experience encountering challenges and also implementing innovations to improve diabetes outcomes for the people most at risk and most affected by disparities. Then, as Emily mentioned, we'll take your questions. Let me take a moment to thank Jeff Brenner, Jim Walton, and Marshall Chin for joining Jeff, Levy, and me this morning to share their insights with you. I really think that their experience will be informative for you in your own work. So, with many thanks, Jeff, to you, let me turn over the discussion, and we'll look forward to it and to the question and answer period following.
Great. Thanks a lot, Noreen, and it's my pleasure to briefly introduce the panel. I'll keep the bios short, though they are long and distinguished, so that we can hear as much content as possible. And the plan is for each of our presenters to give an overview of their programs. Then I will kick off a little bit of a discussion among the panelists, and then we'll turn to your questions. If questions arise during as you're listening to these discussions, please feel free to send a note and send it to all moderators of that. And I will call through the questions as we start the discussion section. So let me introduce our panelists. We're first going to hear from Jeffrey Brenner, who is Executive Director of the Camden Coalition of Healthcare Providers. Jeff is a family physician who has worked in Camden, New Jersey for the past 12 years. He was in solo practice, but recognized the need for a new way for hospitals, providers, and community residents to collaborate. Recognizing that, he founded and has served as the Executive Director of the Camden Coalition of Healthcare Providers since 2003. Through the Camden Coalition, local stakeholders are working to build an integrated health delivery model to better care for Camden City residents. You probably maybe are familiar with his work from the Hotspotters article that Dr. Atul Gawande wrote in the New Yorker. Dr. Marshall Chin is our second presenter. He's professor of medicine at the University of Chicago, is a general internist with extensive experience improving the care of vulnerable patients with chronic disease. He is director of the Robert Wood Johnson Foundation Finding Answers, Disparities Research for Change National Program Office, and he's director of the Chicago Center for Diabetes Translation. He was a member of the Institute of Medicine Committee on Future Directions for the National Healthcare Quality and Disparities Reports. Dr. Chin is leading the evaluation of a Commonwealth Fund project that is implementing the patient-centered medical home in 65 safety net clinics across 5 states. He is also improving diabetes care and outcomes on the south side of Chicago through healthcare system and community interventions. Our third speaker is Dr. Jim Walton, who's Vice President of Network Performance in the Baylor Quality Alliance, which is part of the Baylor Healthcare System. He oversees the Baylor Healthcare System's Accountable Care Organization's performance in achieving the triple aim of better care for individuals, better health for populations, and lower per capita costs. Working with the Baylor Quality Alliance's Physician Board of Managers and its numerous committees, he collaborates with physicians and post-acute care providers in the North Texas region to improve care coordination and practice-level workflows. He also serves as Vice President, Healthcare Access for Baylor's physician organization, Health Texas Provider Network. This work leverages his career in healthcare management, clinical practice, and research related to community health improvement. And so with that, I will turn it over to Jeff Brenner to begin our discussion.
Thank you very much. Good afternoon, everyone. My name is Jeff Brenner. I'm the Executive Director for the Camden Coalition of Healthcare Providers. We're a nonprofit organization that's been around almost 10 years now. The broad goal is to improve quality and reduce costs in the city of Camden by working in a very intensive and detailed way with local stakeholders. My board members are 3 local hospitals, Cooper, Lourdes, and Virtua, 2 local federally qualified health centers, small private practices, behavioral health providers, and various social service agencies. We're hoping to make Camden City the first city in the country to bend the cost curve. The city of Camden is only 9 square miles, and it's 79,000 people, so it's a city where you can round up all the key stakeholders and put them in one room. It's one of the poor cities in the country, and 3 of our last 6 mayors have been indicted and convicted of corruption, so lots of very challenging issues in the city. One of the first things we did in building the organization was to put together a key data set. And we have found it to be critically important to have patient-level data. This was originally a medical student summer project that extended into a project that's been going on for quite a while now. We have patient-level claims data from the billing computers of all 3 local hospitals. Because the city is so poor, people rarely leave the city, so it's a fairly good representation of health data in the city of Camden. We have 500,000 individual patient records for 98,000 patients, stretching from 2002 to 2010. HIPAA allows you to have patient-level data if there's a public health purpose for the data, or there's a care management, care coordination, a clinical reason for the data. When patients go to hospitals and they go to healthcare providers, every time they visit, they typically sign a release at the front desk, and contained in that release is permission to utilize their data for treatment, administrative, and research purposes. This data set is governed by an identical IRB agreement, research agreement, that went to each hospital and was approved by the research board at each hospital. And it's also now governed by a contract that the coalition has with each hospital with a business associate agreement. So it's managed in a dual way. We quickly learned that someone had gone 324 times in 5 years, and that someone had been 113 times in 1 year, that half the population uses an ER hospital in 1 year, that the total payment to the hospitals in Camden, just for Camden residents, to go to the emergency room and hospital is about $100 million a year. The most expensive patient was a Medicare patient with $3.5 million in receipts. 30% of the costs go to 1% of the patients, 80% of the cost to 13% of the patients, and 90% of the cost to 20% of the patients. The bulk of the cost being inpatient hospital utilization. One of the things that we have found very important to do is to differentiate between inpatient utilization and ER use. We often, in the same sentence, lump them together, and the cost implications and even the strategies to address and the patients that are causing the utilization are different for in ER utilization. There are some overlaps in the population, but they are distinct populations. Go on to the next slide. These are the top emergency room diagnoses for the whole city of Camden for all 3 hospitals. The number 1 reason to go to an ER over a 5.5-year period was head colds, 12,000 visits for head colds, 7,000 visits for ear infection, 7 for viral infection, 6 for sore throat, 5 for asthma, 5 for stomach virus. And I can tell you from the receipts, from the payment information in this, that patients are paid $300, $500, $700, $1,000 for a visit. So a tremendous amount of money being spent on the care of these patients. And emergency rooms have tripled in size in Camden. We've built new hospital wings, but primary care offices like mine are going out of business. Go on to the next slide. We've spent a lot of time trying to figure out how to segment this data, or to divide the data up into meaningful and useful frames of the data. One of the segmentations we found most useful is a geographic segmentation. One of the first things that people typically do with a data set like this is to divide it up by diagnosis. And we think that diagnosis is the wrong way to segment this data set. It should be first initially segmented by other segments like utilization segments or geographic segments or cost segments. So this is a geographic segmentation of the data, looking at 5.5 years of data, and this is mapping out the home address of the patient from their billing data from all 3 hospitals. This is the first time that we know of that anyone has taken almost complete data set, billing data set for a city for all the local hospitals and combined it into one map. So this is a map of the city of Camden, and the red areas are census blocks, which are very small geographies in a city. 6% of the census blocks are responsible for are 10% of the landmass, are 18% of the patients, 27% of the visits, and 37% of the cost. The point of this being that 37% of the costs are all coming from a fairly concentrated geography. And the two most expensive buildings in the city are these two buildings, which are both beautiful buildings with great management. Northgate 2 is a building with dual eligibles. It's senior and disabled housing. 600 patients had 12 million in receipts over 5 years. And the Abigail House is a subacute rehab and nursing home that had 300 patients with 15 million in receipts. That's payments to the hospitals for their ER and hospital care. That does not include all the other buckets of cost, and typically inpatient and ER use represents about half of total spend. So the true spending on these patients would be probably double. We don't have the outpatient billing data, unfortunately. On to the next slide. We have taken that frame and that analysis and in the last few years have helped to launch similar nonprofit multi-stakeholder organizations in Trenton and in Newark. They have hospitals, local FQHCs, primary care providers, housing providers on their boards. They're incorporated as nonprofits, and they do many of the same things we do. They have outreach teams in the field that are picking up and managing high-cost complex patients. They are doing work in primary care offices to do primary care redesign. They have a health information exchange up in Trenton, much like we do, and we've begun to help them analyze their claims data. So this is data from the 2 local hospitals in Trenton showing that the geographic patterns of utilization are quite similar, that there are very specific buildings with high-cost complex people living in them up in Trenton. And go on to the next slide. Similar patterns up in Newark. Which really makes the problem easier to deal with. And the fundamental question that we're all going to need to ask ourselves is, do we want to move expensive, complex people in wheelchairs around the healthcare system, or do we want to bring healthcare services to them? And based on the experience we've had in Camden, that every time you move someone who's older and disabled around the healthcare system, there's an opportunity for a drop in quality and for data to be missed and handoffs to be fumbled. That broadly speaking, it's much better to bring healthcare to them. We've piloted an intervention in one of the high-cost buildings, Northgate 2, in which one of our partners opened a 2-exam-room small primary care office in which about 100 people in the building have switched over to that office for their primary care. In our data feeds, every day coming through our health information exchange, we download a report of who's been admitted to Cooper, Lords, and Virtua with their address, their name, their primary care provider, and their address. So we have a real-time way of looking at healthcare utilization in Northgate. Go on to the next slide. This is from a report that is on Maine's website, and it's on our website as well. We worked with the state of Maine, and they gave us 3 counties worth of patient-level data for Maine Medicaid. And we wanted to find out if these basic patterns held up in a rural state. And it turns out in the 3 counties we looked at that are very rural, that high-cost complex people who go over and over to the ER and hospital eventually collect into town centers. And that it's hard to live in the middle of nowhere when you're getting older and disabled and become a more frequent utilizer of healthcare services. I would encourage you to take a look at this report if you're interested in this topic. Go on to the next slide. This is a slide drawn from state-level data looking at Camden, Trenton, and Newark at the top 1% of ER high utilizers from 2007. In Camden, it was 386 patients who went for 5,000 visits, 13 visits per patient, and 80% visit more than one hospital. It's also true for inpatient utilization as well. And the point of this being that in underserved communities, high-cost complex patients who overutilize services are highly mobile. They go from ER to ER, hospital to hospital, sometimes provider to provider. And that the problem is probably better solved at a community level and not just simply at a practice level. That the frame of the problem at which it operates is a community level problem, and that you need community level data sharing, community level interventions, and ways of various stakeholders to come together and talk about how people move across boundaries within the system. Go on to the next slide. We embodied that basic idea in a piece of legislation that we passed in New Jersey. It was signed by Chris Christie back in October to create a Medicaid Accountable Care Organization demonstration project that has a geographic denominator and geographic attribution. And in order to participate in the demo, you declare a geography. You have to have 100% of the hospitals in the geography agreeing to participate, 75% of the primary care providers, 4 behavioral health providers, and 2 community residents. And if collectively working together, running a variety of different projects, you reduce cost in all the buckets of cost of Medicaid, then you can capture a portion of the savings. So we signed a contract with United Healthcare, which is geographic shared savings. So it also allows the Medicaid HMOs to opt into the model as well. So let me stop there, and let me close with one final overview of what we're doing. The Camden Coalition of Health Providers is doing work that's very similar to people all over the country. I think the only thing that's unusual is that the size of the city is 9 square miles. It's a very poor city. And the number of things that we have running under one roof is unusual. We run our region's health information exchange. We've got very detailed data sharing agreements. We run various primary care redesign interventions, as well as care management, care transition teams. So I think it's the breadth of things under one roof that are unusual. Often HIEs are split out as a separate nonprofit. Data analysis is often a separate nonprofit. Sometimes quality improvement is a separate nonprofit. So it's a new. Let me stop there, and thank you very much for the chance to present.
Hello, everyone. My name is Marshall Shin, and I'm delighted to share with you some of the work we're doing in Chicago, trying to integrate team-based healthcare approaches with community partnerships to improve diabetes care and reduce disparities. Next slide. So Chicago is a city of neighborhoods, and if you look at the middle of the slide, there is a map of Chicago divided by its neighborhoods, and the slide shows death rates with diabetes as the cause of death, where the redder the slide, the worse it is. And you can see that the south side of Chicago lights up here as being an area city which has particularly high death rates from diabetes. And I think, like a lot of other cities, Chicago has a number of challenges. There's poverty, a variety of social challenges, food deserts, there's gay activity and crime that can lead to finding it being hard to find safe places to exercise. There's a mistrust of the healthcare system by many of the African Americans on the south side of Chicago. And various cuts in the county budgets have really weakened the hospital and clinic safety net. But at the same time, there are some tremendous strengths in Chicago. There's a great history in terms of social, political, and cultural traditions. Chicago is one of the parts of the country where during the Great Migration, many African Americans in the 20s, 30s, 40s, and 50s migrated from the South, and a number of great institutions have been set up, and a variety of great community resources. And there are lots of healthcare institutions across the south side of Chicago. Next slide. So our project is relatively new, having started about 3 years ago. And I'm going to give you a brief overview of some of the things we're doing. In January of this year, we had an article come out in the journal Health Affairs, which goes into some of the early lessons in more detail. Next slide. So our project has 4 different parts, and the project revolves around the chronic care model that many of you are familiar with from the McCall Institute, which tries to integrate both community approaches and healthcare approaches for improving care. So the 4 parts of our project are first, quality improvement, and we're collaborating with 6 clinics on the south side of Chicago, 4 federally qualified health centers and 2 clinics based at the University of Chicago. And we're engaged in a quality improvement collaborative where there's a quality improvement team at each of these 6 clinics that will meet together as a group among these 6 at least 4 times a year to learn about these techniques of quality improvement and share best practices. But the teams have been doing a variety of different interventions. So, for example, a number of centers have used group visits as a means for trying to improve diabetes care, or another clinic, they have a program called the Diabetes All-Stars, where they are using a number of their patients who have diabetes as experts to inform them about best ways to improve their care and work with the community. So that's the quality improvement part. provider training that we're giving training to the doctors and nurses and staff at the clinics, both in terms of cultural competency, communication techniques, and then ways of thinking about behavioral change with their patients. A third part is patient activation, where in particular one of my colleagues and co-leader of this project, Monica Peak, has developed a culturally tailored method of diabetes education for the patients that incorporates basic training in terms of diabetes care, physical activity, diet, along with trying to improve shared decision making. So getting patients to be more active in their care and to be able to speak up and to engage in a shared decision making process with their doctors and nurses. And then fourth, we have community partnerships, and these are a variety of types of partnerships. One involves public education, so we've been doing a lot of work with, for example, the African American radio stations of Chicago and local cable network TV, for example, as well as community fairs. But then we have a number of partnerships both with nonprofit as well as for-profit organizations. Next slide. I'll give you one example where we're trying to integrate the community partnerships with the other parts of the project. So I mentioned that we have the culturally tailored patient education, but one of the big issues for diabetes care, of course, is that patients spend the vast majority of their time not in the clinic or not in the hospital, but in the community, at home, with their family, as well as your neighbors. And a large part of diabetes care is going to be healthy lifestyle. And so one thing we've done is hook up our patients in the classes with a variety of community resources. So, for example, one partner is CLEO, which is a community-based organization on the South Side, and they have a monthly food pantry to help give out healthy, free food. And during this monthly event, there's a cook who comes from the local community college to basically educate the patients on how to cook with the foods that are given out at that particular event. And similarly, patients who don't have any particular medical home or care at that time, we try to hook them up with one of the clinics, either in our project or a wider group of health that we partner with. And so here's a quote from one of the patients who was in the patient classes and participated in the food pantry. The food pantry helps because it is healthy. I might be running short, and then they kind of fill in, so it all fits in together. It works perfectly. CLEO, community organization, is there as a community thing, and I wouldn't have known about it if it wasn't for the class. It's the one thing to know that you're on the right track, that what you're doing is working, I'm doing what I'm supposed to do, and I'm going to continue. Next slide. So some of the early findings from our project are that the culturally tailored patient classes can improve outcomes. Organizations can change. All the 6 clinics we work with, there's been great movement, positive movement in terms of working together to improve diabetes care. And people are very enthusiastic about the initiative. I think that people realize that basically building upon the strengths of both the healthcare system as well as the community is the right thing to do. And so we've had great enthusiasm from all types of partners about the initiative. And then it's a gradual process that we're 3 years into it, and it's taking time. This is a slow process in terms of building infrastructure, but it's moving well in terms of the right direction. Next slide. Some of the challenges are that integrated healthcare and community approaches are not incentivized. And so at times there's been variable buy-in from senior management, partly because there's at present a minimal business case economically from the clinic perspective. Team-based care is not incentivized in the fee-for-service world, and that these are non-traditional collaborations that we're developing, and few models exist to learn from. Next slide. Some additional challenges are that to basically give it a go in terms of this type of effort, you need to have basic quality improvement infrastructure and buy-in as a starting point. As I mentioned, community relationship building takes time in terms of aligning missions, developing trust, and the time it takes to do this. It's also a challenge thinking about how do you integrate so that these are not standalone interventions. In other words, these 4 different parts of the project, for example, are not isolated projects, but they all together live together and live together with the community. I gave the example of the monthly food pantries. That's one example of how we're doing it. And then the role of the city is evolving. And in terms of both maybe a challenge, but also a great opportunity, we've been developing over the past year an exciting collaboration with the Chicago Department of Public Health. And we're currently doing some of the types of geomapping that Jeff talked a little bit about earlier in terms of mapping out the neighborhoods of Chicago in terms of diabetes issues. And thinking about, well, how can we partner with some of the unique strengths of the Department of Public Health, which they have, of course, have the power of public health in terms of ordinances and mobilization the city to work on diabetes issues. Next slide. So some of the suggestions we developed based upon our early experience are first, it's critical to establish financial incentives, which I think we're starting to see on a national basis. With the passage now and upholding of the healthcare reform by the Supreme Court, built into healthcare reform are basically ways to think about incentivizing caring for our population. Jeff talked about accountable care organizations as one example. Also, there's increasing attention outside the clinic. So different movements such as the move towards global payments, bundle payments, will increasingly incentivize us looking in terms of coordinating care both inside the clinic as well as in the community. There's early talk in terms of actually developing straight performance incentives to reduce disparities, work on reimbursing team-based care and community health workers. Other suggestions we have are really to the importance of convening the stakeholders, which is one of the things that has happened in terms of our overall quality improvement collaborative. It's also critical to give technical assistance. So, for example, in our case, giving technical assistance in terms of basic quality improvement, as well as introducing clinics to integrated care models. And then I think for all of us, it's critical to promote the message that integrating healthcare and community approaches is essential. I'll pass it on to Jim at this point.
Good afternoon. I'm delighted to speak to you all this afternoon. My work, go to the next slide, our work here in Dallas, next slide, is going to kind of take what Marshall has alluded to as well as what Jeff discussed and really kind of drill down on a community level intervention, illustrating kind of how healthcare systems can respond to the macro data once they've identified where these hot spots are, and developing really a model program where community health workers work with alongside primary care physicians in a team-based care delivery. The project that we created through the Merck Alliance is labeled the Diabetes Equity Project, with the goals to initially was really to support Dallas County physicians to provide a standardized approach to diabetes self-management. A few years ago, maybe at the turn of the century, we realized that uninsured people were not able to get into diabetes self-management education, and then also we're having difficulty with ongoing advocacy. And we built a pilot project that we learned from and then expanded with the Merck Foundation funds. But the heart of it was really the expanding of the role of the community health workers within a large healthcare system so that they could have some influence on chronic disease management and supporting the primary care physicians who, by and large, were donating their services to care for this population. Next slide. So the Diabetes Equity Project intervention, in its simplest description, is a patient relationship expansion, a knowledge transfer expansion, and a system expansion. And so the first element, the patient relationship expansion, pivots around a community diabetes education program that we developed with a volunteer endocrinologist that basically is a one-on-one format that includes 7 patient contacts per year and a structured interface between a community health worker and a patient. Obviously, the staff, the community health workers are matched to the patient population by race and ethnicity and language. And the focus really is treatment adherence, disease control, and transferring the knowledge that the AADE has defined as the 7 self-care behavior elements. System expansion for Baylor Healthcare System was really to identify a unique role for the community health worker as an employee of Baylor, participating and making access to self-management education and ongoing advocacy available for patients who struggle with health disparities. To support that group, we created a disease registry program that was with a local IT vendor that our community health workers could utilize to put their patient information in, as well as it produced reports each time a patient was seen by the community health worker, and that report was sent to the referring physician. Now, the community health workers were embedded in 5 different locations, primary care clinics, but those clinics also served as hubs for referrals from other charity clinics in the neighborhood or in the region that could send diabetics over for this service. So in some cases, the community health worker simply had to walk down the hall to give the information to the primary care doctor, and in other cases, they either faxed or scanned and in the future will send by HIE the information back to the physician after each visit they have with the patient. And then, of course, there's trigger tools that enable the community health worker to call the physician or the physician's office should a patient screen as needing some assistance that day. Next slide. So a little background, and everybody has their pictures or their description, and this just gives you an idea of what our demography looks like for those of you who don't know much about Dallas or Dallas County. And we're quickly becoming a minority-majority population, as you can tell here. We have a fairly high uninsured rate in the community with, of course, higher rates for Latinos and for African Americans. And then when you look at the actual percent of medically indigent, or the definition of medical indigent, we have 40% of the population living in the county, which is our target market, is around 1 million people. And you can see there with the demographics that about 2/3 of them are uninsured and 1/3 of them are Medicaid or CHIP. All of those folks have a real difficult time finding primary care, and our public health care system can accommodate about 50% of that need. So we have a 50% unmet need that the private sector steps into in most cases. So our project pivots around this kind of workforce that we believe sits in the community with a lot of resting capacity and resting talent that needs to be accessed by the healthcare system. So the critical success factors for us was that the system had a commitment to improve quality, and specifically the dimension of quality called equity, or reducing disparities or improving health equity. And then the resources that we apply to that was the community health worker, and so that needed a robust recruitment and ongoing training and the ability to have career paths inside of our organization for that employee. And then the third element was the medical home and system recognition of the community health benefit, which is once we deployed the community health worker, that the actual physicians and staff of that inside that medical home had to come to terms with and recognize the value, the incremental value that those providers, this new resource was able to bring to them. So we literally had the community health workers establish their own schedule of patient care in parallel to the clinic's primary care clinician. We have strong commitment to measuring satisfaction, ongoing satisfaction. Every patient, every visit had the opportunity to give feedback, as well as strong clinical outcomes that I'm going to show you in just a minute. Next slide. So we have this ability through the software, next slide, is to produce surveillance data on a regular basis, weekly, monthly, quarterly data. And so I'm going to show you some pictures here of what our staff actually is able to look at on a regular basis. We look at this, in this case, this is the 5 sites in the aggregate, but each clinic's community health worker, each site's community health worker can actually look at their own data. And as you can see here, what we're able to look at is the performance over time of how that community health workers are in, this is in the aggregate, but the individual clinics will look the same, how they are performing over time against some benchmark that we're able to obtain in the greater marketplace. Next slide. So that was A1C less than 7. That's good control, and then A1C greater than 9. This is improving control, that people are outside of control. And as you can see, that over time the N of this population has increased, and we've reached somewhat of a plateau in the percent of reduction in the patients that are out of control. Next slide. This is another element called just blood pressure. How well are we doing with blood pressure? We're also able to show you BMIs and other metrics that we're able to do. So this just, again, illustrates the ability to look at this data in fairly real time. Next slide. And we did have a research analysis, researchers inside of our system start to look at our data in a more rigorous sense and look at kind of what is the average A1C when people are coming in. And I felt like this was important to show you on the webinar today, kind of how sick were these patients when they entered into the program, and the average A1C of being 8.4, and over a year, the average drops to 7.1. So we see this as consistent with other literature of writing about what community health workers linked with primary care physicians, and I think that's the key word, this linkage, that what type of impact they're able to have on patients' A1C control. Next slide. This, we also obviously have an interest as a healthcare system in understanding if this actually impacts the bottom line. In our case today, we're funded by the Merck Foundation, but when the grant money's run out, the question is, will the healthcare system recognize both quality and economic value for the care of these patients? And so these slides start to get at this idea of measuring change in utilization. That was what Jeff was really indicating in his comments initially, was you can actually, when you target these patients with team-based interventions, you're able to start to move the needle or bend the cost curve by changing utilization. And I think that's what these slides represent for us. Next slide. So how do we move to scale? We're kind of thinking that the patient-centered medical home movement supporting population management is really the direction to kind of embed this activity. That it's physician-led, but CHW-delivered chronic disease management protocols and pathways support. And so it's really, this is kind of the essence of team-based care. Clearly starts with a physician commitment at the local site to reduce disparities, that they're actually able to look at their data through the lens of, do I actually have performance differentials inside my particular patient care segment that's different for different races and ethnicities. We clearly need a policy change that say, I'm going to pay for performance around reducing disparities or closing disparity gaps. The system has to be committed to community health worker development, where we think that centralizing the initial and ongoing training and deployment and management of community health workers makes the most sense, is what we believe. And then finally, this recognition of the unique benefit that community health workers bring. We think care coordination payments that exist already in E&M codes potentially are useful for us to actually start to recover some payment in the current fee-for-service environment and in the future shared savings environment for capturing what the community health worker does and what benefit they bring to the table. Next slide. So I'm going to turn it back over to Jeff Levy, and he's going to lead us through a discussion.
Great. Thank you, Jim, and thank you, Jeff and Marshall, as well, for a fascinating discussion. Let me remind you to, if you have questions, to start posting them using the send note function. We already have a couple in the queue, so I think we'll have no difficulty filling up the discussion time. Let me start with a general question, especially since we are now in the week after the Supreme Court decision, and it looks like implementation of the Affordable Care Act is moving forward. And each of you have slightly different programs, but a tremendous interest in how, what you're describing are really things that can be implemented in the context of a reforming healthcare system. And I was wondering if you have any advice for people in the field as their states are beginning to grapple with the issue of implementation, whether it's in terms of the Medicaid expansion, whether it's in terms of the broader use of accountable care organizations, or also, just as importantly, probably some of the other provisions of the Affordable Care Act that move us towards thinking more about community-level interventions, whether it's community health workers or the transformation grants that really try to change the environment in which people with diabetes may be living and needing and getting the support to change their behavior, in a sense, do primary and secondary prevention at the same time. What advice would you have for people? What are you focusing on in the context of implementation of the Affordable Care Act to help bring some of your ideas to scale? Jeff Brenner, do you want to start?
Sure. I think the most important thing is to realize that there's no shining knight on a white horse coming to rescue every community. I think the Affordable Care Act sets tools in place, it sets incentives, it works to begin realigning the system, but it's going to take champions in each community all over the country to actually do this work. You know, for the other folks on the phone, I think all of us were doing this work before there was, you know, we had 2 nickels to scrape together, and you know, even before we got grant money, I think we were doing pilots and small projects. So I think the best projects are the ones that are built with no or little grant money, that are very small pilots. And then when you do get grant money, or you do get a new payment stream coming through the Affordable Care Act, you'll actually have some experience. What I tended to start to see is people get funding, and they get way too much funding, and they try and scale these interventions very quickly. And I think Jim and Marshall would back me up in saying this is really hard work. It's hard to hire the right people. It's hard to get the data right. It's hard to get the intervention right. It's hard to get the relationships right. And you know, sometimes if you get a big giant grant and you're trying to build all that stuff at scale too quickly, it will fall on its face. So you know, I think people who have an inclination towards this work need to build small pilots and get started, and don't wait for Washington, D.C. to say this.
Yeah, I would agree. I think our work started, you know, in the early 2000s with a small $35,000 investment in one site, and really proof of concept, realizing that you're exactly right, that there was nobody really going to help us. We had to help ourselves with reducing or addressing this issue of disparities in self-management education and advocacy to get medications for diabetics experiencing bad outcomes. Obviously, a grant has come along for us to help us take it to the next level, but we're facing, you know, as everybody does, the prospect of that funding going away, and we've got to a decision as a healthcare system whether or not we brought enough value to the marketplace and to the organization to continue the work. And I think that's a positive. I think it's a positive result today. And yet the pressures that are being brought to bear on healthcare systems through the Accountable Care Act puts it as a very vulnerable element of our delivery system, because the more traditional funding, the places that have gotten the more traditional funding of, you know, physician primary care practices and specialty care support services really get most of the attention in major healthcare systems. And so innovation has a tendency to be cut during these kind of tighter times until the financing mechanism catches up, where we actually are rewarded or punished, if you will, punished by decreased reimbursement for a lack of quality improvement or the presence of disparities. We're going to have a difficult time keeping these programs funded in these really difficult, lean times for major healthcare systems, which then, you know, begs the question, will the community step into that gap?
So this is Marshall. I'll add a few comments onto what Jim and Jeff shared. Even though health care reform passed and has been upheld by the Supreme Court, there's still going to be a lot of continuing issues involved in terms of appropriations and implementation on the state level. And so for those of us interested in disparities and vulnerable populations, we do need to keep the eye on the ball in terms of making sure that disparities are, or performance is sort of measured and stratified by vulnerable groups to be able to document that there are potentially continuing issues that need to be solved with the way that healthcare reform is evolving. So keeping the eye on the ball, I think, is critical as we move into implementation. I would say, though, that, again, regardless of whether healthcare reform, how it rolls out, we know that both in terms of public policy as well as the private marketplace, there's going to be an increasing emphasis upon value. And so I think that in terms of one of the common themes I think across our 3 projects are that the idea of coordinating care, integrating healthcare and community approaches, developing care management programs, these will all be, I think, part of the direction that the nation goes in any case, regardless of whether it's public policy emphasis or the way the marketplace is headed. So I think concentrating upon those types of aspects are some of the promising ways to go in terms of reducing disparities.
So one of the questions we had from one of the listeners was around communicating with policymakers, and I'll make policymakers a broad definition, meaning public officials at the state, local, and national level, but also you could consider senior leadership in a health system to be policymakers. And how have you been able to convince policymakers that, besides the fact that you have grant money, and I suppose that is one way to convince them, but to go beyond just dependence on the grant and to start seeing this as something to be integrated into your healthcare system? Jeff Brenner, you were able to do that in New Jersey in terms of the creation of the Medicaid accountable care organizations. What are the arguments that are persuasive to policymakers to have this focus on these disparities, to have this focus on really changing how we think about and do care?
It took me a really long, this is Jeff Brenner, it took me a really long time to understand the point of view of each stakeholder. I mean, truly understand it. I could do it at a trivial level, but actually to, occupy the concerns and feelings and challenges of a hospital official, the state official, the Medicaid health plan. They all have very different views of the world, and they operate in a very specific niche with specific concerns. So it took me a long time to figure out how to make my pitch and my appeal and make work framed in a context that would make sense to them. My current pitch to the hospitals is the bulk of the federal debt going forward is health care, and the biggest chunk of that is hospital reimbursements. There's no way to balance the long-term federal debt without a dramatic change in the amount that hospitals and doctors are paid. It is going to be a painful and wrenching process to right-size and downsize the hospital and healthcare industry. And the ones that will survive will be the ones that can figure out how to innovate. And you don't want to be Kodak and Blockbuster Video, which are examples of entities and other fields of business that did not innovate. So innovation is going to be learning how to do more for less, how to deliver better value. And so I've explained to them that our projects are learning how to do this in a new way, how to manipulate data, put teams in the field, how to reinvent primary care. These are core capacities that they don't have, and that we're an investment in learning how to do those things. So that's a very different way of framing than I've learned how to do in the past.
So we had a couple of very specific questions that are worth answering very quickly. Marshall, one of the questions was about what the metrics are for measuring progress in your program.
It's a great question. That we have a variety of different metrics. Some are more long-term, and some are more patient-oriented, and some are more community-oriented. So for diabetes clinical care, it's in some ways the usual metrics in terms of blood sugar control, blood pressure control, cholesterol control, various diabetes guideline measures. But we're also trying to measure different ways in which organizations change. So our organizations change themselves in a way that they're better able to deliver chronic care or diabetes care in this case. Similarly, we're trying to measure the impact we're having on the broader community. So not just the patients that are parts of the clinics, but how we're doing in terms of community health and making an impact in terms of the community messaging. And so we're trying to now track things like the impact of the various community partnerships we're having that go beyond traditional diabetes quality care measures.
And that measure of what's happening in the community, I think, speaks to a couple of comments we've gotten. One about addressing this at the grassroots level, but the other about sustainably funding public health, local public health, to lead community-wide policy change initiatives. And certainly another part of the Affordable Care Act, which are the community transformation grants, is really designed to create those kinds of community changes. And certainly, Marshall, in your presentation, you talked about things like food deserts and safe opportunities to exercise and those kinds of environmental factors that are going to be critical to any of these programs ultimately working, because the management side does require thinking about both what happens in the clinical setting and making that as effective as possible, but also what happens in the community. One last question, which was for Jeff Brenner, which is, what mapping system are you using?
Nothing fancy. We use Microsoft Access, Linkage Wiz, which is probabilistic linkage software, costs about $1,000, and ArcView GIS, which is the mapping software. So it's all standard off-the-shelf stuff.
Great. So unfortunately, we are running out of time, and I want to turn it back to Noreen for some closing comments.
Thanks, Jeff. Well, obviously there are several threads that weave through the kind of effective change that these alliance leaders are spearheading in their communities. And these threads clearly include information management at a new comprehensive community-wide level of information technology use. It includes cross-community and health system communication, bringing together folks who often don't talk with each other, but their future success is totally dependent each on the other. Another thread is building and, very importantly, integrating community and clinical infrastructure. And yet another is ensuring relevant, effective community engagement, and in the case of the alliance sites, deploying and integrating into the clinical team community health workers. So I really want to thank Jeff Levy, Marshall Chin, Jim Walton, Jeff Brenner, and the Merck Company Foundation for making today's discussion possible. And thanks to you who forwarded questions. As Jeff indicated, we'll get back to you with answers, even though we weren't able to deal with all of these questions in the seminar format. The archive of this seminar will soon be available on the Alliance website, and we'd love you to direct your colleagues who weren't able to join in today to view the webinar on the Alliance website. The address is on your screen now. You can also connect with us on Facebook and Twitter, and that information is on your screen. And check the website, the Alliance website, for the a description of our work, the policies consideration document from the Washington Summit, and the next webinar that's scheduled for September. I hope many of you decide to continue today's dialogue and take action against this terrible problem of diabetes disparities. And thank you very much for joining us today.